예, 보입니다.
Okay. Okay. Yeah. Good morning, friends and colleagues. I think my brief talk about costal cartilage harvesting can be a nice complement of the Dr. Toriumi's talk. So there is some overlap, but I think there is something you can get it. Before going into the chest to harvest the costal cartilage, you have to understand the anatomy of the chest wall. The chest muscle comprised of pectoralis major and serratus anterior and pec minor and external oblique abdominal muscle. There is a rectus abdominis muscle too. And during the costal cartilage harvesting, I think the most difficult problem is inadvertent injury on the arterial artery. So you have to understand that the internal thoracic artery run parallel to the sternum, and then intercostal artery is just below the cartilage here. So you have to be very careful not to perforate the artery. If you perforate the artery, there's blood coming from, you cannot see the exact bleeding point. So it's the difficult issue. And also, you should be able to prevent the pleural injury. And there's a parietal pleura and long visceral pleura. Usually the visceral pleura reach about to the sixth rib, and parietal pleura reach to the seventh rib. So I can tell you that it's safer to approach a seventh rib if you want to avoid the pleural injury. But you have to know that there are huge variation in the anatomy of the patient. So here, I want to introduce you my secret weapon. If you want to make a small incision, I think this Langenbeck green retractor is a nice instrument by which you can expose the cartilage very well. And I don't use any fancy instrument. I just use 15 blade and a free elevator, and Tesio type periosteal elevator is a nice instrument for easier dissection of the costal cartilage. So first I marked the xiphoid process as shown here, and then I marked the rib cage margin, and then I make here's a nipple. I make about 2 centimeter incisions. Here is one caution for you. If you are not experienced with the costal cartilage harvesting, at first you better make a big incision. Then you can have a good exposure and you can run more. But once you get some experience, you can start with a small incision. This is about 2 centimeter incision. And after marking the incision, I do the incision using blade, and then I switch into bovie. Then you can dissect down, cutting the fat tissue, and then you will encounter the fascial layer above the muscle. So then I insert my finger. I think finger is the wonderful instrument by which you can do very safe dissection. Here I expose the fascia layer, and I incise the fascia, and then you can identify the muscle running below the fascia. And here you should not resect the muscle fiber. Instead, you have to split the muscle fiber, and you have to create a space between the muscle fiber. Then you can see the loose areolar tissue covering the costal cartilage. Then I cut this areolar tissue again, and then you can identify the outer surface of the costal cartilage. I usually make a medial cut first, and then I make a lateral cut, and then I make superior cut and inferior cut. During this procedure, you have to make initial incision with a blade, but this should be a partial incision. You should not go too deep. The full thickness incision should be made with Fourier elevator. So this is a tedious procedure. You have to move your Fourier elevator to and fro and back and forth. Then you can palpate by your tactile sensation that you made a complete cut of the costal cartilage. So don't insert elevator to lift up the costal cartilage once you don't have complete cut of the costal cartilage. So as I said, this is not an easy procedure, but you should not hurry. You should have enough time for learn yourself the feeling when you touch down the muscle under the cartilage. So once you are sure that you are in the right plane, usually the cartilage pop up naturally. And then you insert this Tessier type periosteal elevator. And this is a nice instrument. And here you see the endoscopic view of how I use the elevator. And you have to be very careful not to violate the pericondium, inner pericondium. So I'm extracting out the cartilage. Here is the cartilage with pericondium. After the cartilage harvest, I usually fill the space with normal saline and then let anesthesiologist to do the Valsalva maneuver. And then I sometimes use this suction cautery for bleeding control. And this space is filled with tissue glue. So I don't place any drain. I just do a little bit of soft compression. So I sometimes harvest the pericondium for several purposes. And this is harvested costal cartilage. And for the interest of time, I will keep my presentation right here. And I will introduce the next speaker. Today we have truly a giant in rhinoplasty. I think you all know Dr. Rod J Rohrich. He has served as the editor of the PRS, and PRS became a huge journal, and by his effort. Not only his editorial effort, he influenced many surgeons by many good articles, and he taught a lot. And so I'm so grateful to Dr. Rod J Rohrich for accepting my invitation. Thank you. Yeah, you can start your talk right now.
Okay, thank you. Thank you so much. Let me share my screen. And it's indeed my pleasure to be with you at this amazing meeting. I wish I could be there in person. I'm going to talk a little bit about tip projection in rhinoplasty and some changing concepts, some things that we're doing that I think are important. These are my disclosures, and I write books and have instruments, and I give all of those royalties to charity. I'm also a research consultant. And of course, next year we'll truly have a live meeting. This year it was truly one that was hybrid, but certainly one that was virtual. But we invite all of you to come to our meeting. The amazing thing that has changed in rhinoplasty has been, of course, several things: preservation rhinoplasty, but also look at evidence-based data on what truly makes the dorsum and the tip shaping durable and long-lasting. So in modern rhinoplasty today, we rely less on the lower laterals for changes, but we rely on how we get to that change specifically. Is it a septic tension graft? Is it how we tension the lower laterals? Is it the sutured shaping? Well, let's take a look at this evolution of shaping, because I've certainly been an advocate for a long time of the Kayup-Muller strut. And I think the Kayup-Muller strut is a very valuable portion to rhinoplasty, but I think Today, there are so many other options that I think are much more valuable. And certainly I have talked about cardiomotor struts for a long time, and I think they're invaluable for maintaining tip projection. And I still use them for that. And all of you know that it's a mobile graft that's placed between the feet of the medial crura, can be sutured in multiple different ways. This is not a novel technique. And certainly we can take it in a patient like this that has specifically some incredible deviation of her caudal septum, but does not need any tip changes. So you can use a cardiomotor strut to shape that, reshape the dorsum, and get a beautiful result. And this is an ideal indication for a talar contour graft because you're not changing the tip projection. However, one thing we have been doing is we've been looking at evidence-based data on the effect of the cardiomotor strut on tip position. And actually, it's been quite unreliable in increasing or diminishing tip projection. And of course, it does not offer any type of rotational control. Hence, we fast forward to May of this year, and we talked about the beginning of a new type of septal extension graft, which is fixed yet mobile. And I think that's very important to understand that when I have done mobile grafts in the past or septal extension grafts, I did not like them because they were too fixed and immobile. So by taking it off the end of the anterior septal angle, this truly allows us to angulate to maintain tip projection or rotation or decrease rotation in many different ways. And this is a powerful adjunct that I use, especially in my Asian patients, because without it, and I use rib grafts almost exclusively in my Asian patients, you can solidify this with a modest amount of rib graft and hold and fix this very stably, but still have a mobile distal septum. So it's reliable. It does for increasing and decreasing tip projection. So how do we prove that? Well, one of my fellows just did a phenomenal study and won the recent award at the Aesthetic Society that showed the superiority of septal extension grafts, this fixed mobile graft, over the cardiomotor strut. And I think that's very important to note. So what do we do? Well, we looked at a variety of, this is the type of batten septal extension graft that I use, and we compared them to the cardiomotor strut. So what did I do? I actually took some of my own patient data, and of course there's very little data in the literature on this. And the hypothesis was, is it superior? We looked retrospectively at several hundred of my patients from 2016 to 19, and we excluded any of them that were secondaries or had other simultaneous procedures. And we looked at them at their nasal measurements, and it was a blinded assessment of the pre-op and 2 and 12-month post-op. And a normalization of these measurements was done. And we used outcome data based upon the loss of projection and the angle of rotation based upon their nasolabial angle. And we assessed all of these at 2 and 12 months. It was all assessed proportionally by projection and rotation in an equal amount of patients in each group. So what we found was that the cardiomotor strut lost significantly more tip projection and also more rotation in all groups. And if we define this loss of more than 40 degrees of projection and 5 degrees of rotation, there was a 5-fold increase in risk of projection loss and a 2.8 risk of loss of rotation. So that's really significant. Other notable findings were that obviously one thing we know is in patients, in males, they have a much higher risk for loss of tip projection. So we have to maintain something that's very strong. And of course, rotation also had a higher chance of rotational loss in males. So subsequently in males, you can derotate the nose, but you got to be very careful. And of course, in a patient like this, you can use a rib graft. So what is reliable and what is a fixed mobile graft? Okay, it's a very, and I'm going to use this patient as an example, a patient that has needs refinement, derotation of the nasal tip. This is a primary rhinoplasty. Patient broad, boxy tip. So we derotated the nose, put it on a septal extension graft that was fixed and floating, and reshaped the entire dorsum downward, but brought the tip to make it stable and fixed. And I call this the 4 suture technique, 2 into the body and 2 suture stabilization techniques. So the septal cartilage is harvested, or rib cartilage, and then it's sutured into place with 5/0 PDS suture. And you can do it angulation. If you want to increase tip projection, you can put it at 90 degrees from the septal angle. And then if you want to go any further, you can actually put in 4 sutures, one superiorly, one inferiorly. And that's what was done in this patient. So we did an inferior one, so there's very little space for displacement. And this is a very, very powerful suture to use. And so this is the schematic of that. So, but with that also, we began tensioning. And tensioning of the lower lateral is something that's actually not new. And then Rick Davis has really popularized it a lot. And I think that's so key, that once you have a rigid structure, you set your tip projection, then you can place your tip and you can fix it into place so that it's in an ideal position. So you have the ideal position from the tip to the infratibular area. And so that the caudal edge is superior and you straighten the lateral crura. And I think that's very important to do. And I think this is the hallmark of almost all of the rhinoplasties I do today.
So you want to tension the lower lateral.
So you're tensioning this lower lateral cartilage, and you can do it with rib or septum. And what you're wanting to do is you really want to put this in place so that you can do it bilaterally and shape it. And then you can tension the other one as well, and you get that lateral crural tensioning to the septal extension graft that's stable. And then you can place your intercrural sutures. And of course, these are 2 different patients, but it shows the end result of straightening the lower laterals, or in cases like this where you want to further evert the lower lateral, I call this an alar equalization suture that helps you pull it out, and then you can actually further straighten it, and you can actually get further eversion of the lower lateral cartilages. Again, the goal here is to straighten the lateral crura, evert the lower rim, and have the caudal edge be higher than the cephalic edge. So in a patient like this, we did tensioning, septal extension graft, reshaping of the dorsum and tip, derotation of the nose, bringing it down and suturing it into place. Now, in patients that are really overprojected, you can use this same principle. And this same principle uses this same type of techniques, but I almost always take the weakest component to derotate the nose, and that's the medial crura. And this was done in a patient like this with an ultra projecting tip. Now, in Asian patients, primarily it's increasing tip projection. So it works beautifully for these patients. And of course, I use a rib graft almost 100% of the time in these patients. In this patient, we derotated it, we overlapped the medial crura, we sutured it into place, and this just shows this overlap here, this technique where we're overlapping, undermining and overlapping the lower laterals. And in this case, we're transecting it and derotating it. You can truly dial a tip any way you want. And in this case, we did so by undermining it and then suturing it into place, and then bringing it into play with a septal extension graft. And so once you've got it into place, you can do your septal extension graft, you can put your suture in and fix it any way you like. And so you can truly derotate the nose and bring it into play. And of course, in this patient, she also had a cephalic butterfly graft placed to soften the soft tissue triangle, because in these patients, they have really, really, really thin skin. You can soften it in that area. And so you can derotate the nose, you can increase your tip rotation. This is a very powerful, uniformly predictable technique that is superior in my hands to a Kayumara strut, especially in a patient like an Asian patient or other patients that really need augmentation of the nose. So it is excellent for stabilization, rotation, and changing tip projection. Another patient, strong nose, very thick skin, and we wanted to not only decrease the dorsum, but take the tip down and back, but we also wanted to bring the tip up. Same technique, same type of technology, using a fixed mobile septal extension graft in this patient, really bringing it forward and shaping the tip and infratibular area. So these are the kinds of things that I think I really like, that's very, very powerful for us to see. And then it's, of course, it's great in the reconstructive patient. This is a 5-time redo patient for revision rhinoplasty, same type of technique. We did the exact same thing and did a rib graft and a septal extension graft to bring it forward. So in conclusion, the most important thing and the predominant factor in changing tip projection and rotation today, I feel, is a fixed mobile septal extension graft with lateral pearl tensioning and nasal suture reshaping. So thank you very much for your attention, and I look forward to any questions you may have.
Thank you, Dr. Rohrich, for your excellent talk. Here is some. Okay.
And I think the other thing that I think when I use it in my ethnic patients, I mean, I use it a lot in rib grafts, and it's very powerful. And I think the biggest advantage is that it allows you to not have that fixed, rigid tip, and you don't have to use as much rib graft as I have had to before. And so my patients love that.
Okay, what is your thought on the tip grafting in general? I mean, shield graft and tip and leg graft, what is your thought?
Well, I think tip grafts are good if you make sure they're contoured correctly, or I overlay them with fascia. But I can tell you in long term, especially in the thinner skin patients, you have to be careful. That's why I actually like to, I like to use the native cartilage and really spring it up as much as I can. And then I'll use an onlay graft. But if you're using like rib graft there, you've got to make sure you cover it with fascia, mastoid fascia, or I don't like temporalis fascia because it melts away.
Okay. Here's one question for you. What is the typical size of your septal extension graft?
The typical size is about 2.5, 3 centimeters, and it's about maybe 8, 10, 12 millimeters wide. And the great thing is, if you buttress it off the anterior septal angle and put in multiple sutures, it's very, very stable in that. And as we've shown in our study, what you see is what you get. It doesn't need to be overcorrected. When I use columellar struts, I always had to overcorrect my tips by about 3 millimeters. And I showed in our study that actually you lost tip projection, especially in revisions and in ethnic patients. I don't know what has been your experience with that, but I literally have almost abandoned columellar struts except in primary rhinoplasties in Caucasian patients.
I see. Dr. In-Sang Kim, do you have any question to Dr. Rohrich?
I'm sorry, I was a little bit distracted later.
Okay, I see. So in your toolbox, what do you do a lot? Do you rely heavily on the tip suture technique or septal extension graft or tip grafting?
I rely more on septal extension graft today than tip grafting. I don't like to use tip grafts unless I have to. Now, again, in the revision rhinoplasty, thicker skin patients, I have to do that. But by and large, we all have seen so many problems with tip grafts long term. They may look good for 6 months or a year or even 2, 3 years, but then when I see them at 5, if I'm using tip grafts, especially rib grafts, I am really sculpting them and shaping them so that there's really no contact points hardly with the dermis, because any area that's sharp will cause a long-term indentation and deformity.
I think the case selection is very important because the tip grafting should be reserved for the patient who has a thick skin. And some of my trick for tip grafting is that I always try to camouflage the edge or margin of the tip grafting using perichondrium or crushed cartilage. So then we can avoid the risk of the graft showing. We cannot avoid it completely, but I think it can be a good strategy.
No, I agree.
Here, the question. Okay. Do you find some deviation of the tip due to unilateral placement of the septal extension graft?
I have not. I think the only problem I've seen is that when I use rib grafts, sometimes it's palpable and visible in the airway on the one side. I obviously tell the patients about it. But what I do in those patients is I contour the inferior portion so there's no real step off in that area. But I've not seen that as a problem because when I'm putting it unilaterally, I actually can tension the tip so that it stays in the midline. And I think that there's less of the cartilage load that you sometimes see because I see so many patients that have so much cartilage in their nose and they're unhappy because their nose won't move. This allows you to have a very natural looking nose, even with a rib graft.
Okay. Here's one more question for you. Do you have any experience of the resorption of the septal extension graft?
Well, you can get resorption with anything. I mean, I use, of course, I use autologous when possible, but you may know that I'm actually just in the process of publishing. I have used fresh frozen rib grafts for about 9 years in probably 80% of my revisions and secondaries in ethnic patients, and I just have a couple of articles coming out that shows that it's similar to, if not better than autologous, because many of our patients don't want another donor site, and the pain is, even though the way you showed was superb, 1 centimeter. So many of my patients have revision rhinoplasties, and once they've had one rib graft, rarely do they want another one. So, but the resorption is really, it's minimal. I mean, I've now, I have maybe 7 to 9 year follow-ups on patients.
Okay. Here's one more question. Do you use a septal batting graft before septal extension graft? I think both are complementary. So
yeah, I know.
yeah.
But I think that the greater question is, should you use a septal extension graft over a Kali-Muller strut? I think in your patient population, you should almost always use septal extension graft. Don't you think? Because it is so powerful if you want tip projection. I just find myself using a Kali-Muller strut probably 1 in 50 rhinoplasties today.
Oh, I see. Here's one more question. Thank you for the great presentation. How do you decide the side where you fix the septal extension graft?
Very good question. It depends really on the deformity. Like if the deviation, many times if there's a deviation to the right and I bring it to the midline, I always straighten the septum, but I'll put the graft in on the left if the deviation's been to the right. But my real tensioning is when I've got it in place and sutured, then I use the power of my tip tensioning to make sure that it stays right in the midline. And I think that's very important to do. And I know in the past, you can use bilateral septal extension grafts, spreader grafts, septal extension graft. And by that time, you have so much cartilage in the tip, and it's like a excess cartilage burden.
I see, yeah. Okay, I know that the tip suture technique have a much more significant role in Caucasian rhinoplasty than in Asian rhinoplasty. What is your experience? Do you get reasonable, predictable long-term result just using a tip suture technique alone?
Yes, absolutely. In primary rhinoplasty. Now, in primary rhinoplasty, in Caucasian patients, thinner skin patients, yes. In fact, I don't like to use tip grafts, but in thick skin patients, secondaries, Asian patients, absolutely. Many times I will have to use a tip graft, and it's okay as long as you cover them, like you said, with perichondrium or fascia. I think that's fine. But what I see when I do that, sometimes you lose that definition, and so you got to, everything's a trade-off. And I guess I always look at what is it going to look like in 5 years. Because at 1 year, it may look good, but at 5 years, at least my experience in Caucasian patients with tip grafts has been that they don't look that good no matter how you sculpt them. And even the people that have done a lot, like even Dean, who spoke earlier, I think that, he'll use tip grafts only when you need to. if you can tension span your lower laterals and really put it up and press up against the skin with a strong, rigid, or a flex mobile septal extension graft, your nose will look so much better long-term. So I try and avoid it if possible.
Okay. I think we exchanged a very nice discussion about. I will finish your talk with one more question. Here is the question. Caudal septum is smaller and weaker in Asians. Overlapping fixation of caudal septal extension graft might cause deviation. I think this is kind of a comment. Do you have any comment on this?
About, I guess I didn't understand the question. Was it about that it can cause?
This is Dr. Kao from Taipei. He said that caudal septum is smaller and weaker in Asian. Overlapping fixation of septal extension graft might cause deviation. So,
Well, yes. I mean, anything can happen. Now, the key here is you have to have a straight septum. So,
sure.
number one, you have to have a straight septum. You have to have a strong L strut. And I always suture my septum into place with a figure of 8 suture to the anterior septal, to the spine. So he's right, but you know, you have to start and end with a straight septum. And I think that's important. Everything has to be very rigid on the base, but if you come from a rigid base and stabilize it, then you can have some mobility in the tip that'll make it feel a lot more normal. And that's really what we're trying to do long-term. And I think that it's something that we really need to look at much more frequently. Do you use septal extension grafts frequently, or is it, what is your go-to for tip shaping?
Yeah, septal extension graft is one of my workers. I place it almost all my cases. If they want tip projection, they want to have change in the tip angle. So for me, it's septal extension graft is my workhorse.
Well, yeah. I mean, it has to be because you know you're doing augmentation rhinoplasty in so many of your patients, correct? I mean,
yeah. But before applying the septal extension graft, if I can, I usually reinforce the caudal septum with ethmoid bone. Yeah, that's one trick I have.
very, very stable.
Okay.
Yeah.
Thank you, Dr. Rohrich, for your fabulous talk and discussion. I hope to see you again in person very soon. Thank you.
I hope to see you all soon. Take care.
Okay, I see. Thank you. Yeah.
Bye-bye.
Dear participant, I think we better have about 4 or 5 minutes break. We have some housekeeping issue. So we'll resume at about 5 minutes later. Thank you.